Hi, everybody. Once again, my name is Tina Costa, and I am a director with the PHSA Office of Virtual Health. I continue to be your host for these virtual sessions, and it's my pleasure to welcome you or re-welcome you to day 2 of the 2023 BC Digital Health Forum, inspired by Canada Health Infoway's Digital Health Week. For those of you just joining into our virtual circle this morning, we encourage you to share in our collective gratitude for the opportunity to come together from many traditional, ancestral, and unceded territories of BC First Nations. As we continue to engage, learn, and collaborate in the realm of digital health, let us give thanks for the privilege to do so on these beautiful sacred lands. And may our discussions contribute to a future where Indigenous voices are uplifted and the principles of reconciliation guide our path forward. I now have the pleasure of providing a condensed introduction again for our next 3 presenters, Claire Doherty, Marija Stefic-Cubic, and Suji Sim. Claire is the manager of virtual health for Providence Health Care. Claire works with health professionals and software vendors to improve patients' access to high quality healthcare. The virtual health team enables clinical teams to use digital solutions for virtual visits, questionnaires, interpretation, remote monitoring, text messaging, and more. Claire's career history includes leading quality improvement projects, enabling family physicians to learn from their electronic medical record data, and conducting research. Marija is the clinical nurse specialist for surgery at PHC. Through her long nursing career, she practiced nursing in many different areas, such as leukemia and bone marrow transplant, critical care, cardiac cath lab, emergency, geriatrics, and surgery. She has held many different roles, including frontline nursing, nurse consultant, nurse educator, and now clinical nurse specialist. She completed her undergrad study at UBC, critical care nursing at the BCIT, and her master's of nursing at Athabasca University. Suji is a clinical program coordinator overseeing the Adult Inherited Bleeding and Red Cell Disorders program of BC and the Yukon. Suji began her career as a nurse, gaining diverse experiences across critical clinical areas such as cardiovascular surgery, the cardiac catheterization lab, and cardiac surgery or cardiac ICU. In 2021, Suji has successfully completed her master's degree in nursing, specializing in health systems leadership and administration from the University of Toronto. It is my pleasure now to welcome Claire, Marija, and Suji for their talk on From Intake to Outcomes, Digital Questionnaires Across the Circle of Care. Over to you.
Great. Thank you so much, Tina, for that great introduction. And I'm really excited to be joining everyone here from the Cullen Family Lecture Theatre at St. Paul's Hospital in downtown Vancouver on the homelands of the Musqueam, Squamish, and Tsleil-Waututh. So we've got a hybrid event today. We've got some folks here in the theatre, and then we have also a bunch of attendees through the BC Digital Health Forum online. I'll just be giving a brief introduction here, and then I'll hand things over to our main presenters. So just go into the agenda here. We've got first Marija presenting from the surgery program on their experience with digital patient questionnaires. Next, after about 10 minutes, we'll have Suji speaking about the Adult Inherited Bleeding Disorders and Red Cell Disorders program of BC and Yukon's experience with digital questionnaires. And we'll go into a Q&A for about 10 minutes as well. We'll focus on taking questions from the virtual attendees, but there will also be an opportunity for folks who are here in the room with us. And then at noon, the in-person attendees will be able to grab lunch just outside the room. So apologies to the virtual attendees that we can't feed you as well. But we'll have about 5 minutes for people to grab lunch in person, and then another approximately 25 minutes where we'll have Q&A with our friends here from Thrive Health, who will be doing a little bit of a demo of the Thrive Health platform, which we use for digital questionnaires here at Providence Health Care, and there will be Q&A as well. So without further ado, I will hand it over to Marija for her presentation.
Thank you, everyone, and thanks for the opportunity to present at this event. I just sound much better when someone else introduces me than when I do. But my goal of my presentation is to talk about our experience using technology and Thrive within the patient care in perioperative area. So explain why we made those decisions and using the Thrive Health Rehabilitation Optimization tool, and maybe just touch a little bit on how we are planning to use Thrive Health in the future, and like even expand our use of Thrive. That was our project that was really busting in activity came to halt during the pandemic, when the pandemic hit. So we are actually restructuring, reorganizing, rethinking what our priorities are and how we can move forward with surgical care. So just a little bit about a surgical program at Providence Health Care. I'm not going to talk about cardiac because they are a different program, but surgery at Providence Health Care, we have 2 different sites. St. Paul's Hospital provides a high acuity tertiary level of surgical care in 12 operating rooms. And just want to highlight that in that area, we see colorectal surgery, a referral site for the complex colon surgery. So we accept referrals from all over the province and Yukon. So our patients come from diverse communities. Also, our ENT program, St. Paul's Hospital is home for the BC Adult Cochlear and Auditory Brainstem Implant Program. So this is the only one in the province. And MSJ might be a smaller community hospital, but they also have their pockets of excellence. They have a quite large Providence Healthcare Breast Center. We do lots of breast surgery. Actually, 49% of all breast cancer surgery done within Vancouver coastal health regions are done at Mount St. Joseph. And we are also the center for our ophthalmology is the largest program in Canada, and MSJ is home for the tertiary center for corneal transplant and retinal surgery. So potentially also a future home for osteoodontal keratoprothesis, which I'm very excited about it. It's an Italian method of restoring vision in people with corneal issues. It's also known to thin eye. If you want to Google it, it's quite impressive. So hopefully this is going to materialize, which means that we will be the only center within Americas, including North, Central, and South, that provides that service. This service is currently only available in Europe and Australia. So the brief history using Thrive. So we started using Thrive when we created the electronic version of healthcare questionnaire. I have to give a credit to Jeanette Cooper. So she was the one that started this project, and probably out of frustration because most of the OR booking packages were coming to the pre-admission clinic as being incomplete. And they went through the period when they were returning everything back to the surgeon's offices and asking them to send with the paper version of the healthcare questionnaire, just to find out, yes, now their surgeons' offices were compliant in sending the health questionnaire, but they were not filled, which took a lot of our pre-admission clinic nurses' time to finalize their cases and make decision if patient needs to come to the pre-admission clinic for the assessment before surgery, or this patient is okay just to come directly to the surgery without engagement of the pre-admission clinic nurses. So that said, the goal of that was to improve the flow through the pre-admission clinic and improve the surgical screening nurses' efficiency, better utilization of the rooms. I don't know about the other sites, but having a space at St. Paul's is almost like winning a lottery. If anyone wants the office or patient assessment room, so they know what I'm talking about. So it's quite difficult. So, and that said, when we started with our after the implementation of the electronic version of healthcare questionnaire, I think the pre-admission clinic nurses are probably the biggest fan, because it did help their workflow quite significantly. But also that doesn't mean that there are no problems, but not certainly not to the magnitude as they were before. So we did evaluate our pre-admission clinic nurses' performance, and their efficiency has increased significantly. I don't know for many sites, but some of them that I ask how many patients their pre-admission clinic nurses can screen, and it's quite small. So most of the pre-admission clinics are from 10 to 20, and we were doing a good job even before. Now nurses were able to screen about 20 patients before implementation of the eHealth questionnaire, but now they are 35 to 40 patients per nurse per shift, which is like doubling their efficiency. So that was a good sign that we are on a good track to move away from the paper format. So that's it. In around 2017, a surgical program had made a decision that we got to do something about patients that are waiting for surgery, because at that time there was a big focus on prehabilitation and also using our wait time wisely. And instead of just call them wait time that we can't do nothing about, that creates also opportunity to optimize patient health and getting them ready for surgery, because there's a plethora of literature that says the patients are prepared for surgery better if, for example, the iron deficiency anemia is optimized, if their health status is optimized, if their mobility is optimized. While they're waiting for surgery, they are staying less in a hospital. Their estimated length of stay is about 1 to 2 days less, which helps with the patient's flow, but also recovery. And so we thought, okay, how are we going to do that? We have one ERAS navigator and that has to see 3,000 patients as a cancer surveillance, and we don't have a staff. And that's where we kind of thought, oh, let's look what England has done, because they have created a screening tool into their eHealth questionnaire. That was the idea. So when we approached the Thrive Health to help us out and build this screening tool to help us identify the patients that we can actually intervene. So our first project with Thrive was actually to build in a frailty screening tool. That was the time when we were working on opening a frail elderly preoperative assessment clinic. Initially, we started with colorectal patients, and then we moved to the cardiac surgery patients. So today, all surgeons are able to refer patients to the patients at risk, of course, to the elderly clinic on 9th floor. And this has made our delirium, post-operative delirium, much easier to manage, because geriatric team is actually helping us managing it. So it helped us with the goals of care discussion for the patients that may not have to go for surgery. So that was our first project. And then, of course, the pre-admission clinic is anesthesia ran clinic, and patients need to, we also were able to build some screening tool that they need, like a BMI and stop bank, obstructive sleep apnea. So. And then we started to work on, we got some funding from a specialty services committee, and we started to work to try to identify patients that are at high risk for post-operative pain crisis. And this was a big project because we didn't have a validated tool, and the money that we got through the specialty services we used into actually creating the tool with the Department of Anesthesia, doing literature review, collect a copious amount of data because we needed to have about 200 patients for statistical data analysis in order to be able to build this tool in and identify patient at risk. And also within the footprint of pre-admission clinic, we open a transitional pain clinic. So all our patients that are identified as high risk are referred to the transitional pain clinic, where the anesthesiologist and the nurse create a specific plan for that patient. And those patients are usually follow up to 6 months after surgery, and they help with the tapering the opioid use. So. And then we do malnutrition. We build a malnutritional screening tool. So all patients that are identified at risk are referred to the dietitian before surgery. So we have time to intervene. So we are using the Abbott nutritional screening tool. And this is how it looks like for the surgeons when patients complete their questionnaire. So the invitation for patient to complete the questionnaire is sent by the MOA, like their office assistants, as soon as the surgeon gets a consult for the surgery. So keep in mind that not all patients will have a surgery that have a consult, a referral with the surgeon. So, but by the time they come and see the surgeon already has the idea that this patient, for example, this one has a high pain risk score, high malnutritional screening tool. So this patient will be referred to dietitian and to the transitional pain services for optimization and creating the care plan. And the below patient has a high frailty score and high pain score. They will be referred, for example, to the frail elderly clinic, and and also the pain specific individualized pain plan for those patients. So this is we are just evaluating if this transitional pain clinic, how is impacting our patients' pain management, and especially how is impacting the opioid use, because we all know that 25% of patients that are currently using opioids in the community started after they had a surgical procedure because of the pain management. So this, like what the pre-admission clinic nurses see, and that's actually scanned into the Cerner. So we can find, hopefully in the future, we can find a better way to integrate with the Cerner. But that's the conversation for the bigger conversation among our all other sites that are using Cerner. So I'm just gonna, and there are lots of, so that's how we are using it right now. We also have an internal medicine score, like patient with lots of comorbidities will be referred to impact our internal medicine clinic preoperatively. So this way we are able actually to optimize patient and using that wait time in constructively to get the patients ready for surgery. So also it helps with patient education, and it helped with patient engagement, because along the line they have been meeting different healthcare providers and education. So it's much easier. Right now we are working on building in a patient-reported outcome measure tool. So we are hoping to have a baseline score, and then 6 to 8 weeks after surgery, patient will get invitation to complete another questionnaire. We are trying to find out if there are differences, if what patient actually thought is going to happen with the surgery or with intervention is that it happened, if we met their expectations. So. And in the future, it would be great if we'll be able to work on, go back to try to work on the app that would have would see the patient throughout their perioperative journey with our education part preoperatively, then follow up and a remote patient monitoring postoperative. There is the ability to do that, and this is something that I hope we can work after we implement the PROMs and PREMs. Am I good with time? Yes, I think so. Okay. So.
Thank you, Marija, for presenting your experience in surgical units. So I am going to be presenting on outpatient clinic experiences, right? So this is the quote that actually comes into my mind when I actually think back when we actually first adopted Thrive, enhancing the patient experience by streamlining the completion of intake questionnaires and facilitating those sharing of health-related information that matters most to our patients. So short introduction to our program. So it's two programs, bleeding disorders program and rest cell disorders program into one umbrella program. So under bleeding disorders program, we provide interdisciplinary care to people with inherited bleeding disorders such as hemophilia, von Willebrand disease. And other rest cell disorders program, we provide interdisciplinary care to people with inherited red blood cell disorders such as thalassemia and sickle cell disease. Currently, as of today, we have a 931 patient registered active patients under a provincial program for bleeding disorders and 373 patients under rest cell disorders program. So we provide outpatient clinics for bleeding disorders on Monday, Wednesday at St. Paul's Hospital year-round, and also in 4 outreach locations, including Kelowna, Nanaimo, Victoria, and Prince George. And rest cell disorders program, we provide outpatient clinics on Tuesday and Thursday, and we just launched outreach clinics in 2 of the outreach locations in Kelowna and Prince George, and it was very successful. So our interdisciplinary team members are comprised of hematologists, nurse practitioners, clinical pharmacists, and psychologists, physiotherapists, social worker, program secretaries, each for each program, and clinical nurse and patient educator, and myself, clinical program coordinator. And that is the picture of my little family here. So moving on. So what prompted us to actually think about transitioning from one platform or our previous platform to another Thrive is some of the challenges they encountered with the previous system. First big one was a poor patient engagement. So lack of their user-friendly interface and intuitive design resulted in a very high rates of incomplete submissions. I think with the previous system, we had about 2 out of 10 patients actually completed the questionnaires. And with Thrive now, we actually have about 7 to 8 out of 10 patients actually completing the questionnaire. So it's a significant increase. Second challenge that we encountered with the previous system was limited functionality. So their inadequate features and tools actually didn't really align with the evolving needs of the programs and patients that we actually serve. Third one is workflow inefficiency. It actually resulted in care providers not getting the access to data, the patient's data or patient's completion of the questionnaires, not in timely manner. So therefore, it really didn't translate it into the care planning and treatment planning that they actually had. So that was the 3 major challenges that we experienced. So the decision to explore alternative solution, digital solution, was we wanted to actually achieve the objective of enhancing patient engagement and patient-centered experience with the robust tools and features that's going to actually enable that. And therefore, we could actually involve the patients, their care journey actively. So moving from one platform to another platform, it required a lot of work that needed to be done in the back end. And I wanted to actually talk to you guys about some of the considerations that we had. So assessment of the previous system, it was really important for entire team to actually kind of investigate and explore what are some of the features and functionalities and some of the data captured and why is it not working for our program was really important. And it actually allowed us to actually identify the objective and the goal that we wanted to actually achieve with the new platform that we're actually moving on to. Second was a data migration. So we spent probably large amount of time and discussion on this topic. It was a huge discussion. And so first, it was important for us, our team, to actually understand what could Thrive actually ingest and in what format. Would it be the same format that can we actually just transfer just straightforward, or would it be actually kind of in a different format and then we have to actually transfer it in a different program and then transfer it again? So that was actually a big discussion. And second question was what data will be available and where at the expiry of our previous contract, and if those data will be available, and do we have access, or does it have to be a patient actually accessing it? And that was that. And once we actually made the decision to move forward with Strive, then staff training was actually big portion again, and we had to actually provide comprehensive training to our clinicians because that was the one of the challenges with the previous system, that only the program secretaries actually knew how to actually access those patient data. So then the clinician had to actually rely on those program secretaries rather than them actually accessing it. And again, the challenges that clinicians actually experienced was it wasn't actually easy to navigate those systems, and therefore they mainly rely on the program secretaries for that. So we actually this time completed the training for entire family. Therefore, they could actually access the data in a timely manner and incorporate that into their daily workflows. Number 4, communication and change management. So regular communication was sent to the entire team members at a regular intervals and with the crucial timelines for what transition plans that we're actually implementing and when. And testing and quality assurance, we had 2 super users from each program that would actually conduct the testing in the testing environment so that we could actually identify some of the issues and discrepancies we could actually resolve before the go live. This is the team communications that we actually sent out to the patients, and I just highlighted the important part. It wasn't about just the information about the transitioning, but also let them know that they continue to have access to their existing data with the previous account. One challenge I think Marija actually also mentioned about it is the system integration. It's not there yet, so there's no interface it's established between the Strive and Cerner. So our program secretaries continue to upload the PDF version of the patient's questionnaires into Cerner so that it's part of our legal document or EHR for our patients. Some of the key benefits is in its utility and efficiency in gathering PROMs and patient-reported outcome measures. And it's not the entire list of like what we use in our clinic, but I thought maybe I'm going to actually share some of them. So first one is a patient treatment planning questionnaires. Second one is EQ5D5R, which actually assesses the quality of life. And GAD7, it assesses and screens and anxiety disorders. And PHQ-9, we actually also assess for the general depression symptoms as well. Another key benefit is its ability to customize bundle packages of questionnaires, and that actually enables and facilitates the personalized care plans for our patients. These are the 4 packages that I most often use. So depending on the type of patients that are actually assigned to different days of the clinic, I actually bundle them together. But those questionnaires are also saved in the inventory. So if you wanted it, then you can also send it individually as well. Third one is it's a patient reminder feature. So you can actually, you as a clinician can actually set the reminder features at your intervals that you wanted it at a desired cadence. So the system would actually send out the automated email reminders rather than you having to remember each time what to send out. And you can also send out a personalized educational materials in a new invite or at a later time and with the cadence that you want it. So this is probably the last slide that I want to share with you guys. So this is before the Strive actually came into our life and PROM actually became available to us. Is we book the patient visit and then we'll see the patient. Okay, like it's good to see them. Okay, great. But with the Strive and PROMs, so as soon as we actually book the patient visit, then patient gets sent to personal Strive Health account, and then patient shares what's important to them and what they're actually looking for in terms of objectives and goals of the clinic visit. And then in the meantime, our clinicians will actually gather some medical information, lab information, and this is for bleeding disorders clinics. So they actually, patients report the bleeds. So we also review how many episodes they actually had. And then based on the goals, yeah.
I think I'm just going to have to
Yeah,
interrupt.
absolutely.
So unfortunately, we're out of time for our virtual attendees. So we're going to have to skip Q&A, unfortunately. But if you go into the networking section of FeedLoop, you can reach out to me, Claire Doherty, and you can send me a message. I might be able to answer your question, or I can redirect it to Marija and Suji. And then, yeah, we can continue the conversation that way. And for the in-person attendees, we'll have an opportunity to continue the conversation here. Okay.
Amazing. Thank you, Claire, Marija, and Suji. Great information. Really nice to see you guys all gathering there. We hope you guys have a great rest of your day. Enjoy lunch, which I hear is up next for you guys. But thank you again. And we will take this opportunity to put up the poll to get some feedback right now for our virtual attendees to fill out. Great presentation. And invite everybody to certainly join into our next session if you are keeping on the virtual side of things, which is entitled Trust Sphere. Sorry, I've got to get that out there. Collaborative and personalized digital shared care experience, co-creating with patients, families, and clinicians. Again, you can navigate there by clicking on the session title on the panel on the left-hand side of your screen. Thank you again, Claire, Suji, and Marija. Have a great day.